Administrator for the Self-Management Program of Southeastern Ontario. We would like to welcome you to the 10th of our series of Lunch and Learn webinars for healthcare professionals, which is a part of our efforts to build various communities of practice in the region. I just have a few housekeeping pieces to mention before we begin. As you will notice, you are all currently muted. In just a moment, I will unmute everyone. If someone is on the phone but for some reason cannot access the webinar piece online, please speak up at that time and I'll take down your information in order to troubleshoot offline. Then before beginning again, I'll mute everyone once more. If you have any issues during the webinar, please get my attention by virtually raising your hand. And you do this by clicking on the hand icon that you should be seeing on your webinar dashboard, and then you would type your issue or comment in the chat box, which is also in that same area. I am now going to unmute, so just a moment. Okay, so if there's anybody online who's not able to, on the phone who's unable to get the online component, please let me know now. Or if you're having any other issues that you would like to bring up. Okay. So I'm just muting everyone again then. If you are on the phone and for some reason can't speak up, like the audio is not working or you have any other technical issues, either now or later during the webinar, please let me know by emailing me at the selfmanagement@kchc.ca email. That was also listed in your reminder emails the day before today and a week ago, and I can troubleshoot with you offline via email. So what I would like to do now is also mention that we'll be answering questions at the end, but please feel free to type them into the chat box as you think of them if you're worried about forgetting about them. And then we'll also have a question and answer period at the end. At that time, once we're ready to do so, I will then read out the questions out loud and unmute everyone, the person who asked them, so there could be a back and forth between you and the presenter. And then if it seems like we should have a bigger discussion, I'll unmute everybody and everybody can just chip in. If you would like a printout of the slides with space for taking notes beside them, they can be downloaded. Sorry, I'm having problems speaking today. Downloaded from our website, and the direct link was provided in your reminder emails as well. Now I would like to present our speaker for our 10th webinar, the overall wrap-up of all key materials, tools, and keynote pearls, which is Tanya Burr. Tanya is a registered nurse who graduated in 2007, previously a critical care nurse with experience in ICU and emergency at Quinte Healthcare. 3 years of primary care experience as an RN, an accreditation coordinator, and best practice and quality care coordinator. Currently, she's employed as a care coordinator at the Southeast CCAC and also casually at Quinte Healthcare as a nursing supervisor or admin coordinator. She is in her final year of completing the nurse practitioner program at Queen's University. So now I'm going to pass on the screen to Tanya, which will just take a short moment, and then she'll continue on with the presentation. And Tanya, we should be good to go when you are.
Well, hopefully everyone can see my screen okay. If you cannot, for any reason, certainly make Danielle aware, please. As she said, my name is Tanya. I'm going to be going through kind of some of the more important pieces of all the different webinars that have taken place over the last year. There's a lot of information, and what I've done is kind of section them off so that it gives you a bit of an idea as to the process we went through and some of the things that we've covered. Again, if you have any more questions about some of these topics, you can find all the archived previous presentations on the website, the Self-Management Program of Southeastern Ontario website. And they're available there for download. Take advantage. There's lots of great material there. Okay, so to get started, again, this is an overall wrap-up of all the key materials. The tools are all available, again, online on the website for download, and some of the pearls that went along with each of those webinars. I'll take questions at the very end and do my very best to answer them. If I cannot answer them for whatever reason, certainly I'll get an email from you, and I will get a hold of that presenter, and I can ask them or facilitate asking that question to get you an appropriate answer. So what are the benefits of change? As I'm a facilitator for the Choices and Changes program, I'm a big believer in change. So, and there certainly are benefits to it. So there's patient and client improved health status. We can see that with smoking cessation, with healthy eating, exercise. There's all that improved health status. There's clinicians have increased satisfaction. You probably know as well as I do that when you facilitate that change, people, particularly clinicians, you feel more satisfied with the work that you do. You feel like you've made a difference. The health system has reduced costs. Long-term costs of smoking are significant, so reducing that cost and that illness that's associated is really important right now fiscally. And family and friends have greater availability. You're around longer, you're more healthy, you're available to everyone to go and be with and spend time with and socialize. And at the same time, a clinician would have more time as well to go spend with their family and friends. And you have increased work productivity as well. So not only can the patient or the client stay at work longer, but you're also more productive as a clinician as well. So just some facts and figures about chronic disease. So chronic disease accounts for 7 out of every 10 deaths in the U.S. Some of these are U.S. stats. Now ours in Canada align pretty closely. These include heart disease, cancer, and stroke, which account for 50% of deaths. 25% of people with chronic conditions have difficulty with daily activities such as walking and bathing. We certainly see that, with people who have COPD, morbid obesity, some of these really difficult comorbid and chronic conditions that impact those activities of daily living. And then in turn, these people require assistance to complete these, and this is a different cost on the system as well. Chronic diseases share common risk factors which are modifiable. We look at alcohol, drinking, drugs, weight, activity, exercise. All of these are modifiable in nature. Chronic diseases have overtaken infectious diseases as the leading cause of death and disability. So instead of people, dying from pneumonia or dying from an infectious disease, they are dying due to these modifiable chronic diseases. Almost half of all adults have one chronic condition, and chronic diseases have overtaken, again, infectious disease as the leading cause. So what's important, and I want to take the first step to think about family. Often in our interviews with patients and clients, we focus on themselves and just them, forgetting to kind of take into account all of those social and psychosocial factors, because that needs to become part of that plan and part of that care plan. So self-management with family, and Tina Kinmond was really great in facilitating this for us, and again, her notes and all of her PowerPoint presentations are online. So what are some of the issues related to chronic disease management in family? And with patients, it's physical. So what are the physical demands, or what are the physical deficiencies with that person right now because of that chronic condition? Emotional. So I think we all know that hand in hand, chronic disease is very much linked with depression and anxiety. So the patient has to deal with those on top of those physical deficiencies. Relational issues. How is that family getting along because of that chronic condition and because of the care or the time that that patient needs? And financial burden. We see this day in and day out. Can patients afford their medications? Can they afford the care that they need? Can they afford the physiotherapy that might come with that chronic condition? Can they afford food security, eating well? There's lots of demands that we as providers try to put on our patients. They need to follow this food guide. They need to take this medication. But remembering about those resources that that patient has to work with is really important. And then on the opposite side is what is the family dealing with? So that family has to deal with that emotional roller coaster as well. They need to deal with perhaps grieving the loss of what their loved one used to be able to do, or what their husband used to be able to do, or their wife used to be able to do. Again, the financial burden. Are they looking at, savings and pulling out of their savings, or pulling out of different areas of their budget to afford this new medication or afford a new set of care? And then relational again. How is that that tension affecting that family dynamic. So what are some of the coping strategies for families? So there's counseling, and I think that's a really important one. Counseling for the patient, but also counseling for the family. You can't just treat one part of the family as a whole, particularly, if they're very close and living together, but you're more likely to have that behavior change if everybody is on board. To learn stress and relaxation strategies. There's lots of different programs out there for stress and anxiety. I'm sure if you're from a community health center, or even if you're from a family health team or some of those organizations, they run these programs. Education is big, and that's part of primary care. So educating your clients at that level about resources, but also about the actual condition and what they can do to support their loved one or support themselves. Recognizing their limits. So recognizing that what they used to be able to do is not necessarily something that they can do now, and coming to terms with those. And that leads into the next part of acceptance. The other piece is building in fun. So within all that work, being able to build in something fun that they can do with the family. And this is particularly, again, important if they have young children in the family. So making the best out of their situation. They need to change expectations and attitudes, again, towards daily life sometimes, learn a new way of life, and that can be extremely difficult. They need to access support and resources, whatever they are in your area, whether it's a clinic program, whether it could be Triple P in the area, which is a program for parenting, and they need to set goals. And we talk a lot about setting goals, particularly in the Choices and Changes program, and how important it is to set small, measurable goals. Big, lofty goals are often not met, but if you can help your clients to really work at small, measurable goals that are attainable, then you're more likely to move into that next level of change. The next webinar we talked about was diabetes self-management, and Karen White from the Community Health Center in Belleville, Quinte West did a really good job, and she's a certified diabetes educator, and again, her notes are online. But the diabetes self-management is very important right now. Diabetes is certainly on the increase and on the rise, and I think we all, as primary care providers, whether you're working as an RN, an RPN, an NP, a physician, really need to have a good understanding of what that means. So one of the main models is the cognitive behavioral model. So we can change the way we feel by changing the way we think. So that's the core teaching of cognitive behavioral therapy, and you probably will hear CBT thrown around a lot. When we balance our thoughts, we regulate our mood, which enables us to engage in more positive behaviors. And we also need to gain a better understanding of our negative self-talk, so before we can change those problematic thoughts. So if your client is constantly saying, I can't do this, this isn't going to work, probably likely it won't. So you really need to kind of understand that negative back talk and help them through that. The layers of our cognitions include negative automatic thoughts. So sometimes these thoughts are automatic for people and they just happen. So helping them to understand that as well. And then you have to look at core beliefs, values, and what you're assuming and what they're assuming, and make sure you're talking through all of that to kind of get to the core of everything. So the diabetes counseling model, it's CBT and motivational interviewing, and it addresses anxiety, depression, anger, other emotions related to diabetes distress, so that frustration, the loneliness that comes with it. Often people feel like they're the only ones that have to deal with this, and it's important to address that there are, in fact, lots of other people that are dealing with these same issues. Diabetes education is seen as a collaborative process, and I think that's the key thing here. It's not one person working with one person for change and better health outcomes. It's a team working with a client and their family, and everyone has to be involved with that, whether they're seeing the RPN for blood work, the RN for some education, the certified diabetes educator, whether they're seeing the NP or the physician. Everyone really needs to be on the same page and working towards not their goals only as a primary care provider, but also what are the patient's goals, and those need to be included. Counseling support focuses on the patient's efforts, not just the results. Another really important piece. If that person is really trying, they need to be given credit for that. Just because they haven't met that goal doesn't mean they're not trying, and perhaps the goal is the wrong goal. So let's focus on something else as a goal, or make the goal smaller and more attainable. Interaction should be more rewarding for counselors and educators and more empowering for patients. So in the end, you really want your patients or your client to walk out feeling like they can do this. And at the same time, as a counselor, as a health educator, whatever role you're taking with that person, you want to feel like you're helping them make a difference in their life. So in a quick summary, and this does no justice to Karen's overall presentation, so please have a look at it. Focus on your alliance and the relationship with the patient first. So we need to have a therapeutic relationship with somebody before we can move forward with trying to change health behavior. You want to collaborate. So the patient is expert in his or her diabetes, and you are an expert at facilitating change. Together, you move towards a positive health outcome, but that patient needs to be involved. Their family, if they have somebody close to them, they need to be involved, and the team needs to be on board with the same goals. Once the thoughts are balanced and moods are stable, behavior change is possible. So those other two pieces are there, but now we need to look at some of that CBT. We need to look at that automatic negative thought pattern, those assumptions, all of those different pieces that Karen talks about in her presentation. And then if the motivation is not apparent, it's far more productive to focus on building a relationship than to set a goal. And this comes down to the basis of that Choices and Changes program. If somebody isn't in the mode to actively change, you need to work at what stage of change they're in. If they're in a pre-contemplative stage of change, addressing an active plan is not going to get you anywhere. If they're in a contemplative state of change and they're thinking about it, you need to figure out whether they need more. Are they convinced they can do this? Do they need some confidence that they can do this? So you need to kind of figure out where they're at and how to approach them, and certainly move towards making them or helping them to become more motivated. Luba from the Community Health Center, Luba Shepard-Taki, did a medication self-management webinar, and again, they're listed online. It's a fantastic presentation. She talked about, how to help your patients and your clients self-manage their medication. So what's considered to be a medication? Prescription medications like antibiotics, blood pressure, and other medications. There's over-the-counter medications. I won't go into all of them. Natural health products are medications. They have side effects, herbals, homeopathic medicines. And then there's those traditional medicines. In my area, there's a large reserve, Native American, and there's a lot of medicines that we might not think to ask about that are traditional medicines that could potentially interact with their other medications. So all of those are medications we need to think about when we're asking clients what are they taking on a daily basis, on a monthly basis, when are they using these. So there's some requirements for successful management. People have to be willing, they have to have a willingness to succeed. They have to want to take them. They have to be on board to want to take them. There has to be the cognitive ability. If somebody is not capable of adhering to a medication regime that has a TID dosing or a BID dosing, then we need to figure out a different plan, prescribe a different medication, figure out something that is cognitively able for them to do it. So whether it's putting things in a blister pack or a compliance pack to make it easy, we need to look at that. Functional ability, can they open up the bottles? Can they count? Can they see? All of those different things, again, we need to make sure that not only are people able to take them, but are they able to actually physically get them out to take them. And then their overall well-being as well. So there are certain patients that are at high risk for medication adverse events. There's a number of, so if someone is taking a greater than or equal to 5 medications, multiple changes to patient's medication regimen, which is why it's really important for that continuity of care, but also that everyone on that team is on the same page and that polypharmacy piece doesn't happen. Patients discharged home without support, so being discharged from the hospital with a medication change and the primary health care provider not being aware. Patients being given a medication they're already taken, but what's happened is that they are given a generic brand as opposed to the name brand, and they don't understand the difference, and they take both. I've seen that happen a few times. Principal diagnoses of cancer, COPD, heart, stroke, heart failure, diabetes, depression. Those are some big risk factors because usually they involve a lot of medication and changing dosages, and then a prior unplanned hospitalization within the previous 6 months. And often that's due to a medication change in hospital, not being reported back to the primary care. So there's a model of medication self-management. And again, Luba goes more into depth with this, but I did want to point this out. There's a 6-step model that provides a comprehensive examination of the range of tasks that individuals must successfully complete to manage their medication regimen. It helps healthcare providers to understand the complexity and challenges inherent with medication self-management. Medication self-management is really difficult. I think we've all had times where we've been given medication, maybe not finished those dosages, given up, there's side effects. There's all these different pieces that come into play, and people just quit taking their medications or they don't take them correctly. So in order to kind of get to that change or to allow people to resolve some of their issues, we need to make sure that they're adhering to the regimen, that they're taking it appropriately, that they are managing their side effects, all of those different pieces. So suggestions on how to help with medication self-management. Provide a client with the Knowledge is the Best Medicine Handbook, and Luba has put a link on this on her archived webinar. And it has information regarding the safe use of medicines, what to ask your doctor or pharmacist, and it includes a medication record book. You can order them in bulk, so I put that number on here so that your clinic or you as a provider can order these. And then at the same time, there's a great iPhone app. If you have a really, techie kind of patient or client, you can use the MyMedRec iPhone app, and it's no cost, and it certainly helps people as well as providers manage. So the next step, we had Carla Vandervoort from the Community Health Center, the Belbecune West, who's one of the social workers, talk about self-management with chronic disease and social work, and the really important overlay that they can have with helping us move towards behavior change as providers, clinical providers. Social work, so this session, this is what they look at in a holistic assessment, and the key is that holistic assessment. So they look at a bio, a medical history, and a current status. They look at the psychosocial aspects like mental health history, past concerns, past diagnoses, drugs and alcohol history and current status. That drugs and alcohol history is extremely important when we think of mental illness and addictions. There's a lot of overlap. Spiritual, religious and spiritual beliefs and involvement. And then there's the social history. What's the family history like? What are the social supports? Partners, friends, do they have a brittle support system, or are they really well supported within their community? Recreational activities, education and learning, employment and income and housing. And the next part is, what are the client's strengths? What are they capable of? What other resources do they have access to? And then looking at where they are on their stage of change. When they wrap up the appointment, they really focus on reflective listening. They provide a snapshot of the entire session. And when we talk about choices and changes, we talk about how this is a really important tool to build that relationship, to provide empathy, reflective listening, to ensure that you're taking in what they're saying, you're understanding it, you're bringing it back out to that patient or client to make sure that you haven't made any assumptions in what they've said. Make sure you leave some time, because there could be some more questions. They're really good at making sure that that client feels well wrapped up at the very end. You want to summarize the potential goals or the goals voiced by the client. And then they allow the client to choose a goal or consider an appropriate focus for counseling in between appointments. What I find social workers are fantastic at, that sometimes perhaps as providers you might not have the luxury, is follow-up. It's really important to follow up, and we talk about this again in Choices and Changes a lot. You need to follow up, you need to have some face-to-face time, some telephone time, but you need to have contact. They also focus on interdisciplinary and interagency care, making sure that there isn't anything that's being done in double or replicated. There's not a service that's being replicated for whatever reason. So the challenge is that complex clients' ability to self-manage can get lost in situations where there's lots of agencies and different philosophies. You can use care conferences with the client present. Give them the option, because their goals are super important and actually probably the most important to work on as a team. And then the client establishes, in collaboration with the social worker or whoever is really going to take the lead on this, a list of invitees, and an agenda. And Carla was really great in her presentation to provide a sample agenda for anyone interested. The next webinar was chronic pain and self-management. I think we all know that chronic pain is certainly a big ticket item as of late, and I think it will become even more important in the future. We need to all have a really good understanding on how to assess and how to treat and how to self-manage chronic pain. So clients with chronic pain need an answer to the questions, and you need to have a realistic approach. So is a cure possible or not? Is it sensible? Is it realistic or achievable? Realism needs to be balanced with the need to promote the patient's well-being and optimal potential, and it's not easy. This is a really difficult thing to do to manage chronic pain. What I find is helpful is that you really need to give them a realistic idea that with pain reduction, they can really expect at most a possible maximum of 30% decrease. So if their pain is a 10 out of 10, you can tell them that they can at max most likely expect a 7 out of 10 pain decrease. Their overall improvement in function is the biggest piece. So are they more functional than they were before? That's a good understanding that perhaps something's working. And then their advancement of their capability to self-manage. Enhanced tolerance to exercise is really important. Successful treatment goals often include behavioral changes, an impact on self-image. So looking at an increased self-image, increased self-esteem. Their coping skills become more adequate than before when they were in quite a bit of pain. They have an increase in progressive social engagement. So there's less of that exclusion, and they certainly have more of an ability to see friends and family. You know, before we talked a little bit about that availability to family and friends, and that certainly becomes more obvious when chronic pain is treated, so people can be more social. And self-management skills. And there's lots of different programs for chronic pain. There's the mindfulness program and some of the different pieces that are in the community, and these help to teach those self-management skills. So the successful management of chronic pain, it needs to be a logical and reproducible approach, and it needs to consist of a detailed history and physical. So what happened in the past and what's happening right now. The appropriate testing that can expedite a diagnosis, so whether it's an ultrasound or whether it's an X-ray. I know there's lots of limitations on X-rays on backs right now. Do they need an MRI? Do they need a CAT scan? Certainly, do you need to, in my case as almost a nurse practitioner, I suppose you would need to consult with your MD perhaps. So you need to establish realistic and preferred common goals to further treatment and/or evaluation. You need to construct a treatment plan. That treatment plan needs to have the client's goals built into it. If they're just your goals, it will not work. It needs to have their goals as well. They need to be willing to work toward those. And they need to have flexibility and adjustment of treatment. So based on intermittent assessment and client questioning. So if you're finding that the course of treatment isn't working, everyone needs to be able to adjust to a new, different type of treatment, perhaps a new approach, in order to facilitate that peak type of optimizing place for that client to be. So mutually agreed upon goals and destinations. So clients and healthcare providers should reciprocally communicate and identify likely results of treatment. So that, 30% decrease in pain, increased function, increased exercise tolerance might be some goals. What are the unlikely results of treatment? The unlikely results of treatment might be a complete cure. That's probably unlikely. The role and responsibility of provider and client. So what am I responsible for as a provider, and what are you responsible for as a client? Expectations of all the parties, whether that be you only see me for your pain medication management, you complete this log, perhaps you need to do a random urine, whatever your clinic decides upon as a group. What are the past experiences and possible influences, not only with chronic pain, but with success at behavior change? And what are those alternate strategies? Are they based on mutual decisions and informed consent? Have you told everything possible to the client, educated and informed them, and have you both agreed on this course of action? The next one was done by Christine Young at the she did Healthy Eating and Self-Management, and she's a registered dietitian at the Bubblecombe West Community Health Center. Again, her presentation is wonderful. And healthy eating certainly is a big piece of, chronic disease and how we look at, what are we putting in our bodies and how are we managing, obesity and all these different issues. And she's a great, her presentation is a great resource for that. So what is needed? Again, a readiness to change. So somebody has to be ready. Don't refer them to the dietitian if they don't want to, because it's not going to work. Capacity to buy food and food security is a big issue. Do they have enough money to buy the foods they need to be healthy? Knowing about programs in your area, like the Good Food Box, is really great because it can give people access to food and healthy food. Knowledge of healthy food, balanced meals, calorie awareness, understanding nutrition fact labels. People need to be able to prepare and cook food. So there's lots of skills that go with healthy eating, and people need to understand all of those before they can then approach that actual ability to eat healthy. Literacy, so tools needed, pots and pans. If somebody doesn't own a stove, they're living in a boarding house and there's no access to any of the tools, it's pretty difficult to eat not processed or takeout food. And at the same time, if somebody can't read a label, they're not going to know what they're eating. People also need a safe place to learn and practice these skills as well. Food-related habits, they matter. So the timing, the pattern, the composition of your meals. So when are you eating? How often are you eating? What are you eating? What's your percentage of carbohydrate versus protein versus, vegetables and fruit? The rate of your eating, how fast are you eating? How slow are you eating? Emotional eating, so that food and emotion type of relationship. So are you eating, again, because you're lonely or bored? Talking to your clients about these different issues. Social drinking, your eating habits. Do you eat out a lot? Do you drink a lot of alcohol? When you drink a lot of alcohol, do you happen to ingest a lot of food that isn't perhaps healthy? Past history of dieting or weight cycling, that chronic yo-yo dieter. And sleep adequacy. If you're not sleeping, are you up eating at night? Healthy eating and exercise is really important. So it's a lifestyle change, and most of us try to avoid the word diet. It's a healthy lifestyle. So living well with diabetes or chronic conditions workshops, these are some of the things offered at the Community Health Center. Referring your client to registered dietitian or health promoter when they're ready. Be aware of free or low-cost programs in your community that can support, such as the Good Food Box. Examples being the YMCA often offers subsidized memberships. They have an indoor track. The community health programs like the Urban Polling, which is free, Healthy Bites workshop, where they teach you how to cook those foods, working on wellness, and the Good Food Box. So those are some examples. Your areas, depending on where you're listening from, might have some different programs. Find out about them, see what's out there. Motivational interviewing and self-management. So key elements of MI, collaborative, only the patient can make the necessary changes. So the motivational interviewing approach involves active collaborative conversation. You need to be on the same page, patient and provider. It needs to be evocative. So MI's purpose is to evoke from the patients the motivational resources for change that they already have. People inherently have motivation. We need to certainly use motivational interviewing to evoke this. This presentation that was done is archived, and it is absolutely wonderful. So download this, have a look at it, read it through. You will be glad that you did. And you have to honor the patient autonomy. And again, we talk about this in choices and changes. You really need to accept that people make their own choice and live their lives the way they choose to live them. We can only accept that our guidance and advice may not be followed, or it might be. So I think it's really important, in order to achieve satisfaction as a primary care provider, you need to understand that people will make their own choices, and that we're certainly there to guide them, but we're also there just to simply accept that that's the choice that they've made. There's 4 guiding principles. You need to resist the writing reflex. So we have to suppress this writing reflex, and this is the need to fix our patients and everyone. We want people to start fixing themselves, and that's kind of one of the big goals of self-management. They need to understand and explore the patient's own motivations. So ask your patients why they want to make a change and how they might do this, rather than telling them that they should. People don't like being told what to do. It's a really important, sorry, a really important piece of information, and no one likes being told what to do. So remember that when you're in your interview or your meeting with your patient. Listen with empathy. People want to be listened to, and inherently if you just listen, sometimes you can make more ground than if you're constantly butting in and speaking up. And empower them. So patients understand their lives and their situations better than we do. So listen to them and how they think they might change, and then try to work with that. Asking and listening together. So make sure you're asking open-ended questions instead of closed. Try not to ask 2 questions in a row. Try to offer at least 2 reflections for every question. So when you ask a question, you get an answer, reflect it back to make sure you're understanding the meaning, and do that twice. Try to. A reflection involves paraphrasing or summarizing what a patient just said in a statement and not a question. So that what I'm hearing is that you are having difficulty quitting smoking because your husband is still smoking too. That would be a summarizing paraphrase, essentially, because it's not a question. And it does not include any advice or judgment. Helpful questions for setting goals. What are some small steps that would show you that you are inching towards the goal? Have you broken your goal into smaller steps? And we talked about that earlier, small attainable steps. How many weeks or months will it take you to reach your goal? What would be the first sign that you're making progress? That's a really good question. If a friend set this kind of goal, what would you say that he needs to do first to get started? And then check with your patient that the goals are focused on changes the patient can make, not changes they want others to make, and that the goal is realistic. And I think that's really the key. Is the goal realistic? Are the steps small enough that they can make them? So that's kind of that. Hopefully I didn't rush that too much, but that's kind of what we covered over the last year. There's, again, so much more information that's available on the actual Southeast, or on the website, the self-management website, with all the different archived links. Download those PowerPoints, and again, if you have any questions about a particular point in that PowerPoint, I can certainly facilitate an answer for you. But does anyone have any questions or comments right now?
There doesn't seem to be at the moment, but I'll also unmute everyone just now in case anybody wants to speak up. So just give me a moment to do that.
Okay.
So does anyone have any further questions or comments for Tanya or myself? If so, you can just speak up because you're unmuted. Oh, except for maybe Roger. Roger, you're the only one that's still muted because you did it on your end. So if you need to speak up, you'll need to unmute yourself. Otherwise, you can stay as is. Okay, well, in that case, Tanya, did you have any last comments then, or?
I think really it's just if you missed any of the other, webinars, really take a few minutes and go back and just look at the PowerPoint presentations. Some of them will have some really great little tips, and most of them have some really great tools that you can download for your own practice, for your clinic, wherever you happen to be working. Maybe it's for a friend that works with a particular group of people and you think would be handy. Sometimes those tools can go a long way to, I guess, really facilitating that behavior change with a client.
And everyone will receive a follow-up email tomorrow, which is sent out in an automated fashion. But in that email, there will be a link to that archive page to our website that Tanya's been referring to, because it'll send you so that you can refer to this recording. But in that same section, there'll be all the others. And if there was ever handouts given out, and also the PowerPoint slides with spaces for notes beside it, all of those are posted up with the recordings in our archives as well. So I guess if that's it for you, Tanya, we'll just thank you everybody for attending, and we hope that you found it interesting and beneficial. We will also keep you up to date as to what's going on in the future with our webinar series, as this was the last one for this current session. We're looking at maybe trying a different time of day or some different topics going forward, but hopefully we'll get them going again in a month or two. and we will send that out to our list of contacts once that's all finalized. In the meantime, if you come up with any other questions or concerns, feel free to contact myself at that self-management email that was in your reminders and will be in your follow-up email tomorrow as well. Or if you had questions for Tanya directly, she has offered up her information as well. So in that case, thank you, everybody, and have yourselves a great and good upcoming weekend. Thanks, and have a nice day.